complete and integrated spinal care, no matter what it is. We should be able to take care of it.
Yeah, I agree. It really offers the best of all worlds from orthopedics, a very large physiatry group that can focus on the injection therapy, the conservative efforts, and then if things would progress to the point where somebody might need a surgery, we offer all aspects of surgical care from intradural, which might not mean a whole lot to the layperson, but within the spinal compartment itself, all the way out to the osseous structures or the bone. And we've got 8 spine surgeons, and I'll brag on them a little bit. I think we've all come together to kind of offer the best of both the orthopedic and the neurosurgical side of things.
Yeah, I think we have, as a group of all 8 of us have really come together and put this new product out there for our community. And we've started to do more and more outpatient, minimally invasive surgery center cases at both our South Haven location as well as our Germantown location. And the outcomes, speak for themselves. I think both our patient satisfaction ratings as well as our outcome ratings, when we measure them with objective marks, such as the Oswestry and the VAS scores for back pain, we see that the patients do improve tremendously after, they received their indicated surgery from any one of us.
Yeah, and that you just reminded me that the mission statement of Ortho South is to be the best orthopedic practice in the country, judged and based on the patient experience. So
yeah.
Outcomes is one part of that, but when I hear patient experience, just as myself would want to be treated, that starts at the intake process, the first phone call and through the front desk and through the initial office visit, making sure we do everything to get the right diagnosis, get the patient onto the care that they need. And if we get to the point of surgery, it's offering the best surgery with hopefully the quickest recovery time, and that dovetails with the minimally invasive that we're going to talk about tonight, is getting people in the surgery quickly, getting them out of surgery quickly. In the outpatient setting, that means not having to stay in the hospital. Hopefully we can talk tonight about what minimally invasive means as far as small incisions, hopefully less pain, less recovery time, quicker return to work and activity, and all those sorts of good things.
Less blood loss, less risk of infection. And that reminds me, our surgery center in Germantown was named in the U.S. World in News Report recently as one of the top surgery centers. And it's the only surgery center in the area that offers both spine surgery and orthopedic surgery at the same time.
Yeah, that was a big deal. Just recently published. So I know that probably, I don't want to put an exact percentage on things, but I know the majority of your practice is minimally invasive, and I would say mine is too. And the majority of my practice is outpatient spine surgery. So I guess we can talk a little bit about what minimally invasive surgery actually means when it comes to the spine.
Absolutely. People don't really understand what that means. They hear laser, they hear endoscope, they hear all these other things that are out there in different markets. And really what it boils down to is, the incision size matters, but also what that brings with it, right? You have, because the incision's smaller, because you lose less blood, you don't have to stay in the hospital. There's less pain, right? And then there's also less risk of infection, like I said, less blood loss. And over time, really, there's less degeneration and muscle wasting that comes with big open operations. And that's been proven data-wise, where we see that the objective back pain scores for open operations are not as good as the back pain scores of minimally invasive operations 5 years down the road. We've proven this with objective data, and it's out there, and it's been touted as the techniques that changed the face of spinal surgery, because really it was a paradigm shift. I don't know what you think about that, but I believe that at some point during our careers, the paradigm shifted to where if you don't know how to do, or you don't offer minimally invasive spine surgery nowadays, you're probably a little bit outdated.
Oh, I agree with that 100%. In fact, when you and I were roughly the same age, so we started our training around the same time, and when I was looking at residencies, minimally invasive was kind of like a hot topic. Like, you want to go to this center or maybe this center. There were about 2 or 3 in the country that were pretty well renowned for minimally invasive. But now, you're exactly right. If you're not doing it, you're behind.
Yeah, and if these surgeries are not being done in an outpatient setting, you're probably doing the patient a disservice.
Right.
Just because of all of the parameters that come with the outcomes of the patient service, the rate of infections, and all these other things. Sometimes these hospitals are so big and clunky that you don't get as personalized a service, or as a patient or as a doctor, because as a doctor, what we want when we go to a center is to have the most effective scrub technician that knows how to do the case with us, to have the most effective anesthesia that has done the case numerous times specifically with us, and to have a good team in the background, making sure our instruments are complete and clean, making sure that everything is waiting ready to go for you when you get there at 7 o'clock in the morning to start your minimally invasive fusion. Like today, I did one at the surgery center here in Germantown, and it went flawlessly. I mean, it doesn't really matter. The one thing that I do like about minimally invasive, besides all the other things we talked about, is that it's I call it the great equalizer, because it doesn't matter how big you are as a patient. The incision doesn't get any larger. When you do an open operation, the bigger you are, the bigger the incision that you get. With minimally invasive techniques, the incisions are the same size all the time. And, I got there to the surgery center today. All my instruments were ready. My scrub tech that routinely helps me had a day off today, but she decided that she wanted to come in and help us out today, because I think she helped you out in the case too, because Jason did a case after me. And so she decided she wasn't going to take a day off because I had a case, and she wanted to come help. And, we finished the operation in a little bit over 2 hours. I think it was like 2 hours and 5 minutes. Patient did great. We were done by 10:30. The patient went home before noon. Great outcome, no complications. And again, like I said, the patient service is excellent. The doctor service, the service that we get, because we demand certain standards, and the service I got today as a physician was second to none. Anesthesia was great. Our X-ray technician was fantastic. All our instruments were ready. The drill, nothing. There was no hiccups, and that's usually what you want when you go to a surgery center. And our surgery center performs so many cases every day that it's.
So what you did today was called a TLIF, or
Yes.
Which is an acronym it stands for transforaminal lumbar interbody fusion. And we put together a little slideshow presentation for the audience to describe what that technique is. But before we get to that, I as you were talking there, I just thought of a couple things I think we probably should elaborate on, because patients will call, and of course, everybody wants the minimally invasive, the outpatient, the quick recovery, I want to get back to work as soon as possible. And And it's great when we can offer that, but I do want to point out that there are some conditions that might not be best served with minimally invasive techniques, and we've got to do
Absolutely.
perhaps a bigger operation, and the hospitals are the place for that, and we may need to have a couple days length of stay. That's the beauty of having a spine institute where we can offer all breadths of care, and we've got partners that do all walks of that, from the simplest up to the highest complexity. What I was going to ask you to elaborate on, and I can fill in too, is what kind of conditions lend themselves to a minimally invasive approach?
Well, usually if patients herniate their disc, right, or they have a sciatica, as they call it, it could be any one of the nerves in your back that's being pinched that causes that same type of pain. And when you come and you're evaluated by us, we try to figure out where it is. We look at the MRI, and that's a condition that it's easily addressed with a minimally invasive technique. We do the microendoscopic discectomy, right? We have a very small incision, about 16 to 18 millimeters, and we use the tubular retractors. And
so you're talking about the herniated disc.
The herniated disc.
Caitlin, can you guys pull up for the audience a picture of what it's the first slideshow that we put together? I just, for the audience.
Oh yeah, absolutely.
I wanted to show the first one, the other one. Yeah. Go to the next slide. So that's an example of an X-ray, which won't show hardly anything in the setting of a herniated disc. It shows the bone, and so then we go on to get an MRI. And MRI is great because it shows the soft tissues, it shows the disc, it shows the nerves, it shows the nerve roots, and that's an example of a L4-5 disc herniation. So you can see at that second to last disc level, there's a big teardrop looking dark spot right in the middle of the spinal canal, and that's a pretty big disc herniation, and a patient like that's going to come in with pretty bad leg pain.
Yeah, that's what they usually complain of. Usually when there's a neurologic deficit, or when they're in terrible pain, I always offer them an operation. I don't know how you address these. I'm a little biased with surgery because we can do it with such minimal tissue damage and adjacent consequence. There's absolutely no issues when we do these, and we've gotten them, I think, to have no complications. I mean, I haven't, knock on wood, I haven't had a complication in these for a while.
So that's a great example of what lends itself well to a minimally invasive technique. That's a case where an incision would be about 18 millimeters in length, which is a little bit less than an inch. Typically about 30 to 45 minutes on the operating table.
Yeah.
And most patients will go home at an hour or two after surgery.
Exactly.
And the nice thing about that is, once the incision's healed up, they're pretty much back into the routine of things. And, we always caution about, doing really strenuous stuff, but for the most part, people are kind of back to their lives pretty quickly.
Yeah, they go back. In fact, the other day, some patient we did a discectomy on wanted to go back to work on Monday. His surgery was done on Thursday. And, if you don't do anything strenuous, like, drive forklifts or work at FedEx lifting things and stuff like that, we usually let you go back to work.
I guess, you want to open it up for a couple questions at this point before we move on to some other things?
Yes, I do have a few, actually. It's quite funny that you mentioned the forklift. Someone asked, how much time would I need to take from work if I am a forklift operator and lift boxes from the ground?
I would say, depending on, first of all, what the pathology is. If we're dealing with a herniated disc, I don't know, Jason, what your criteria are. We're still sort of working hard at the Spine Institute to try to standardize some of these postoperative instructions, but it really depends on how the case goes, right? If you have, there's different types of disc herniations. If you have a completely extruded disc, which means some of that jelly inside the jelly donut is completely pinched off the center, we just go in there and do what's called a sequestrectomy, where we take out that piece of disc that basically entirely pinched off and is pushing on the nerve. Those guys, I'm usually a little bit more liberal and let them go back to work faster. If you do a disc like probably the one Jason did that he showed earlier, those cases probably have a big tear in the containing fibers of that disc. And so in those cases, we sometimes have to go inside the disc and pick up all the free fragments. And some people are a little bit more aggressive than others, and there's really no right or wrong way of doing this. The risks of reherniation are anywhere between 5 to 10%, and that's a universal number. Like everybody that does a discectomy will get reherniations every once in a while. But for a forklifter guy that had a annular tear in a discectomy, I would probably err on the side of caution and keep him off of work anywhere from 8 to 12 weeks. I don't know, what's your sort of...
Yeah, I would agree with you. I like what you said. I mean, there's no cookbook way of doing this because everybody's an individual.
Yeah.
And the guy that operates the forklift and has to lift 50-pound boxes at work is not the same as the
office worker guy.
Office worker, or so I think there are some general rules of thumb. I would say 3 weeks of relatively taking it easy, no heavy lifting, bending, and twisting is a general rule of thumb. But when I used to take care of the athletes at the University of Memphis, it would be a 12-week recovery process before we let them go back into the weight room. And the reason for that gets at what you were saying. It's a little bit arbitrary. I don't think there's any hard and fast data on that, but the more time we give for that scar tissue to form over where that disc ruptured out through what's called the annulus, let that scar form and firm up, minimize that chance of early reherniation, I think is a general good rule of thumb, but doesn't necessarily have to apply to everybody.
Exactly. And, for the guy that operates the forklift, it's, if we tell you can't go back to work sooner, it's probably because we're just maybe a little bit worried that, or whoever did your discectomy, that, maybe the annular tear was a little bit bigger than we see in a standard case, or maybe because sometimes we actually have to make the annular tear a little bit bigger so we can get these bigger chunks that are loose in there out. Because if we go in there and we feel that there are chunks of stuff that might reherniate easier than something that might be tethered to the actual vertebral body, we have to make an effort to try to get him out to minimize that reherniation risk. And sometimes to get those things out, we have to make the orifice a little bit larger with our instruments. Some people use a laser, some people use a knife, some people just make sure that they make it bigger some way or another. They have other instruments that we can use.
Perfect. Thank you both. We have a question here from Mark. He asked, have you ever had any experience with devices such as Minuteman or Zip, etc.? I take care of my wife and have lumbar stenosis and spondylitis on L3 and L4. I'm hoping for something that doesn't require as much time to recover as a bone fusion would.
Minuteman.
Interspinous spacer.
Is that the spacer?
I do have experience. Some of those are brand names, and I think what he's referring to are interspinous spacers for stenosis. It's an option. I've done a couple of those in the very distant past, like 15 years ago. Spondylosis doesn't necessarily mean you need a fusion. Spondylolisthesis, there's very, very good data that decompression alone in the setting of spondylolisthesis, not necessarily spondylosis, you're going to be much better served with a fusion. And so the newer interspinous spacers there's channels in them that allow posterior fusion only. It's an option. We can talk through those options. I have not been quite as impressed with the outcomes from a long-term perspective. They may offer 6 months, a year of relief, but
Yeah.
Most of those that I did way back when, I ended up having to revise.
Yeah, and there's a reason for that, because the way these devices work is your spine is usually straight, right? And what the device does, it just basically distracts the posterior elements or separates them. And by doing that, you give room for the nerves that are inside to come out and not be compressed so much. When you do that, you also stretch all of the ligaments that are holding your joints together. And so sometimes the bones that you put the Minuteman in between are not strong enough to sustain it, so they'll collapse again. And sometimes, even if it doesn't collapse, if you restenosis for another reason, if you take the Minuteman out, you're already unstable. And so you're going to have a fusion just because of all of that distraction and ligamentous stretching that happened during that procedure. And again, it's one of those things that, you every time you do something, there's a consequence. And so part of what Jason's saying is that, when you come to see us, you guys can have all the questions. We may not have all the answers, but I guarantee you we can talk through all your options and tell you what our experience is, what the data shows. Because again, here at the Spine Institute, every month we get together, we talk about cases, we talk about the new data, we talk about the new devices, talk about articles that have come out recently that show X, Y, or Z is better than this, that, and the other. It's not, again, it's not a static set of rules that we have. It's something that our profession is something that is ever changing. And so as such, the Spine Institute is committed to staying at the cutting edge, as well as trying to offer our patients the best that modern medicine has to offer. And one of the ways that we think we're effective in doing that is getting together every month, all of the Spine Institute, and not only running through cases, but also running through new articles and new techniques and things of that nature.
Yeah, and like Mark asked on the question, if it was a matter of stenosis that did not require a fusion, without looking at the films, just hearing the story, I would much rather serve somebody with 2 small incisions and do a bilateral decompression, and I know that I'm going to get those nerves freed up quite nicely. I'm not going to destabilize the spine, and that's another great application for minimally invasive technique. That's an outpatient surgery. People do very well with that.
Indeed.
It's for neurogenic claudication, which is bilateral leg pain.
Yeah.
Worse when walking, legs feel tired, give out. That's another great application for minimally invasive technique.
Oh, I agree 100%. And doing it minimally invasive, because these operations used to be done in an open fashion, or still are. But again, the advantage, I think, to the minimally invasive approach is that you go in on the side of the spine and you spare a lot of the supporting structures of the spine. You have this ligament that goes all the way from the bottom of your skull all the way to the sacrum, and that's called the posterior tension band. It's a bunch of little ligaments that join each part of your spine together. And when you do it open, when you do a laminectomy or a decompression in an open fashion, you have to disrupt that. If you don't disrupt it, you really damage it by exposing the area, just the surgical technique that people use. And with the minimally invasive approach, you completely spare all of those supporting structures. And again, even if you have a little bit of a slippage, there's some measurements that we go by that if you don't have greater than a certain number of millimeters, you could be a very good candidate for a decompression surgery. And I can guarantee you almost 80-90% of the people don't need another operation, and they do have good relief of their symptoms. And, you don't need to put any hardware, you don't need to put any screws or do anything. All you have to do is you take a good look at what's inside there and you decompress where you think the symptoms are coming from. And when we do it minimally invasive, we can get the same results as other surgeons do with an open approach.
Yeah, so I think that's a good segue. You did a fusion in the outpatient surgery setting
Yes.
today, somebody that needed screws and rods put in their
Yes.
spine. And I hear that from a layman's perspective, like, how can you put rods and screws in somebody's spine minimally invasively? That doesn't make sense. So
Yeah, it's something that you have to sort of wrap your mind around after seeing how it's done.
we pull up the that case presentation. So you want to walk through how you want to show our
Sure.
listeners like what you did this operation today. I've done these operations in the outpatient setting.
Oh,
It's
absolutely.
usually about a 2-hour case, maybe sometimes a little bit less.
Maybe sometimes a little bit more in my case.
And people go home 2 or 3 hours afterwards once
Yep.
they get up and start walking. Traditionally, lumbar fusion, say 20 years ago, 3 or 4 days in the hospital.
Drain, infection,
big open,
blood loss, maybe
open
blood
incision.
transfusion,
a lot of muscle splitting, a lot of muscle
a
pain.
lot of back pain. Yeah.
Those things are really quite avoidable with a technique like this.
100%. Not only that, but one of the best things I think about minimal invasive surgery is that it really opens up this type of operation to the older population that needs it.
Sure.
Because again, you're not losing so much blood, right? So there's no fluid shifts. So for the layman out there, what happens when you lose a lot of blood is that a lot of the fluid compartments in your body have to shift one to the other to try to compensate for the blood loss. And so if you are an older patient, you can have heart issues, you can have lung issues, and all these fluid shifts can cause issues with the functioning of all these other organs. And so in a way, indirectly, because we're not losing blood, we're not taking so long with a big open incision that's going to change your body temperature, is going to damage a lot of tissue, and it's going to cause a lot of leakage from all of these compartments. It's safer for the normal patient, but for the older patient, it helps them to be able to tolerate it much, much better. It's still a pretty steep recovery time, comparing it to just like a little small decompression, but not like it used to be before where, people could have heart attacks because of the stress that a big operation with a big incision and a lot of blood loss could cause, could put a strain on their system.
Sure. No, there's no age limit for a T-lift.
No, my only thing, and again, it's different surgeons have different standards and stuff like that. But I require the patient to have good bones. So there's ways that we have to find out whether the patient has good bone health, right? And obviously, if the patient has medical issues, the older they are, they're going to need more medical workup so that we can basically optimize the patient and get them as best as we possibly can before we undergo an operation. But yeah, no, I don't think there's an age limit. I agree.
No,
with
I
Jason.
did a 2-level minimally invasive T-lift. Now that was done in the hospital. I did that last week on somebody in their 80s, and they did relatively well thus far. So
Yeah.
Everybody's unique, and take every case
Exactly.
for the uniqueness that it is the best way to say it. So,
Yeah.
why don't we show the audience how a TLIF
Absolutely.
works? So that, go back to the first slide. Just in general, that cartoon you see on the left-hand side of the screen is basically what we're doing. We're operating with what's called a tubular retractor. So if that tube, Dr. Cardenas uses a 22 millimeter diameter tube. I use a little bit larger one, 26 millimeter diameter tube, which, the incisions end up being on either side of the spine. So 2 incisions, each about 1.5 to 2 inches in length. That gives us all the access we need to essentially drop 4 screws, 2 rods, and a graft well into the disc space.
Mm-hmm.
And we'll walk you through what that looks like. So next slide. So that's what a classic case would present that would require a TLIF. That's called a spondylolisthesis. And I don't have the benefit of having a pointer to draw circles around the slides, unfortunately, but what you'll see on those, the MRI on the left and the 2 x-rays on the right, is that at L4-5, which is the second to last disc space, if you look closely, those vertebral bodies don't quite line up with one another. So the L4-5 vertebral body is slipped forward.
Yeah.
L4 is slipped forward on L5. If I had my pointer, I'd be circling that for the audience. I hope they can kind of appreciate that. So.
Yeah, so if you count from the bottom, like triangular shaped vertebral body is the second one up. And then that disc space in between L4 and L5 is the one that slipped. Usually patients present the same way. Patients present with disc herniation and stenosis, basically, because it's both of those conditions combined into one, actually.
And bad back pain.
And bad back pain. And so, we evaluate the patient. Sometimes these conditions can be chronic. And obviously, when we come to the decision of doing surgery on them, we've exhausted all other modes of conservative management. That's why the Spine Institute's great.
Like anti-inflammatories, physical therapy.
Physical therapy is great.
Pool therapy.
Pool therapy
is great for this condition.
We have a pool.
And then, of course, all the injection modalities.
Oh yeah, we have a pretty hefty group of physiatrists here and pain management doctors that help us with that. We'll see the patient, we'll prescribe physical therapy, we'll direct them whether pool is best for them or doing some other modalities. But certainly if that doesn't work, the next step would be to refer them to one of our physiatrists. And we usually have absolutely no problem getting them in pretty fast to get a epidural steroid injection or transforaminal injection, which is what helps with these types of cases.
And so I think you and I are probably pretty similar, almost utilize a surgery like this as a last resort.
100%.
So next slide.
Can we pause for just a second? We do have some
Absolutely.
questions. The first one, Dr. Weaver, you mentioned earlier about spondylolisthesis. You're kind of talking about the inner body spacer versus minimally invasive. Jackie asked, so if I have spondylolisthesis, is this not for me, the procedure?
Well, what we're going through right now would be the procedure for spondylolisthesis, assuming, like we were just saying, all those conservative efforts failed. So, again,
I mean, really, if you have pain that goes down, that correlates very nicely with the level of the spondylolisthesis and all that stuff, this surgery was designed specifically for people with spondylolisthesis. There's a lot of bad juju out there where people say, oh, don't have your back operated on, don't have fusion because it's terrible. You'll never do well. That's absolutely not the case. If you have the pain is unrelenting, you've tried all modes of conservative management, and you have spondylolisthesis with the stenosis and the leg pain and the back pain, this surgery was specifically designed for that patient.
That seems like a perfect intro to presenting this. I'll let you take it away.
So I don't want to spend too much time on the technique. I want to give people a flavor for what we're actually doing in the operating room. So those two slides are lateral views. It's kind of the start of the case where we drop skinny little guide wires by X-ray guidance into the pedicles, which are the walls, if you will, of the spinal canal, down into the vertebral bodies. And then those guide wires are going to serve for us to place threaded screws over the top of them throughout the case and accurately place them down into the vertebral body to give this stable purchase that we need. And then working through essentially an 1.5 to 2 inch incision, we're able to get those 2 screws in on the one side and then pass a rod through that same incision on that one side and set that down into the screw heads, which are shaped like a tulip. And then we place screws on top of the rod to sink it down into the screw heads. And then next slide. And that's a view through our operating microscope where we're working through that tubular retractor, again, about 2 inches in diameter. That gives me access to get rid of all the bone. The top image there on the right is a drill, drilling away the bone of the back of the vertebral elements called the lamina. And then once I have the nerves exposed, which is in the bottom picture, I'm able to work around the nerves down into the disc space. So we can go to the next slide. And once I've made a window in the disc space, which is what I'm doing on the left-hand 2 slides, we're able to place a paddle shaver down into the disc space and start to really aggressively remove all of that soft disc material. So also what that does is rough up the end plates of the vertebral bodies a little bit. It's ultimately going to create a good fusion bed for us.
That's right.
So next slide. And then it looks similar, but that's not the same paddle shaver or spacer that is I was referencing on the last slide. That's the actual expandable cage. You use an expandable cage also?
Yeah.
So I think Dr. Cardenas and I use all the same equipment and technique. And that, what you see there on the right-hand side of the screen is the cage. It's the X-ray of the cage. And that allows us to crank it open.
It's kind of like a jack, like a mini jack.
And it opens that disc space up, which offers some indirect decompression on the nerves. It helps us realign the vertebral bodies, which I'll show in a little bit. And you can go to the next slide. And all this is taking place, the steps I've walked you through really have taken place over the course of about an hour so far. And so once we get that cage in on the right side, if you remember what the last side looked like, we've opened it up a little bit. It expands more open in the front and the back, which creates lordosis of the spine, which is the normal curvature as we look at from the side, which is a great, it's a newer type of cage. The earlier cages didn't have that nice ability to replicate the anatomy that we want. So it's another nice benefit of modern implant technology. Next slide. And so once all that's done, that's the end product. Those are the 2 small incisions. I put a ruler on there for reference, and you can see that they're a little under 2 inches in length.
Yeah, that's about.
Go to the next slide. And so that's the post-op films compared to the pre-op films when the patient came back 2
Yeah.
or 3 weeks after for his follow-up appointment. Those are standing films now, and I put them for comparison because you can now see the more normal alignment of the spine. That slip has been reduced back to a more normal
Yeah, it's
position.
a little bit taller disc space there.
Taller disc space, and the nerves have been decompressed. And so not only is the back pain better now, of course, there's the surgical soreness to get over,
Yeah.
but back pain's better. Leg pain is virtually non-existent. That's an example of a minimally invasive TLIF, transforaminal lumbar interbody fusion for spondylolisthesis, done outpatient, same day. Patient went home a couple hours after surgery.
It works. It's a great operation. Again, if you have the right condition and the symptoms correlate with that condition, this is an operation that could help you get rid of the pain once you've exhausted all other modes of conservative management.
So for this procedure, Jackie asks, do you consider a bone density test first, a bone density test?
Yes, I personally do for all girls over a certain age. And actually, most patients over a certain age, I'd want to get an idea of what their bone health is. And I've had x-rays because, you can kind of get an idea of the patient's bone health by looking at the x-ray. And I've had x-rays that have fooled me. If I hadn't gotten a bone density test on the patient, I would have probably done a fusion on them and gotten a big complication, because sometimes when you're osteoporotic, those screws can't really hold on to the bone really well, and people have instrumentation failure, it's called. And so this being an elective operation, yeah, the patient's in pain and all, but we can start them. They have these anabolic bone medicines now that can increase your bone density in a matter of months. I mean, I've seen it. My dad had to have this type of surgery, and he had very bad bone density. And I started him on this medication, and at 6 months, his bone was hard as a rock.
You do have a positive feedback, Dr. Cardenas, from Kevin. He says that you saved his life, an excellent doctor, and has the God-given talent.
Nice. Well, he's on the payroll.
I do have another question for you. This is from Sheila. She asked, it's kind of a scenario based. So she had a discectomy surgery over 30 years ago. My disc was ruptured entirely, I believe, C5, 6. Now discs C7 and C8 have fused, and I have pain in my neck and down my back left side shoulder blade due to the narrowing of the space, approximately 6 meters or 6 centimeters. Would I be a good candidate for the procedure you're offering?
She'd be a great candidate for us to take a look at her.
Yeah, I think that's probably the best answer, is that, they're taking a good history of physical, all the imaging. It starts with a thorough workup in the correct diagnosis, and then going down the treatment algorithms.
100%.
We would want to try all the conservative stuff too.
And just to tell Sheila, here at the Spine Institute, we welcome everybody. You want to walk in, come in and see us. I have clinic
Easy.
tomorrow.
Make it
Jason's
easy.
got clinic. I don't know, what days do you see patients?
Monday, Wednesdays, and Thursdays.
Yeah. And then, like, for example, I know that Tuesdays, for example, I'm at Exeter, but also Dr. Eager, who's one of our partners, is also at Exeter. I think Sam Shrelicky sees patients at Bartlett location or at the Park location. I mean, we have...
Well, there's 12 spine providers. So
Yeah.
on any given day,
Exactly.
we've got probably 4 or 5 different doctors that are readily available, and we all see same day appointments.
Mm-hmm.
It's our mission to make it easy on
The patients.
to schedule. We can schedule by phone or online,
Or just walk up.
on the Ortho South website. So I think we'd be doing anybody a disservice by trying to offer a diagnosis with a
without any pictures or history. Yeah.
But we do want to make it easy for people to get in.
100%.
All right, so the next question is from Melanie as well. She said, I had a posterior lumbar fusion, L4, L5 in 2016, and I tore my annular nerve in my back 1 year, 6 months ago, and I've been having epidural injections without any pain relief, looking at this as the last resort. So more of a comment than a question.
Man, we'll be happy to take a look at Melanie whenever she wants to come see us. Again, there's 8 spine surgeons. There's 4 interventional pain management spine doctors that can see these patients at any point in time. And we have 2 extenders, nurse practitioner extenders that also see patients.
One last question. This is from Stephen. He asks, how does this work on cervical problems, old age, not trauma?
Minimally invasive is definitely applicable to the cervical spine too, in kind of the same manner for posterior approaches. Anterior approaches require more of an open incision, but those incisions are very small.
Very small.
Unlike posterior big open incisions where you have to fillet muscle, the nice thing about anterior incisions is you're all through tissue planes. And so
it's
not really a minimally invasive technique per se to go to the anterior spine, but the nice thing about anterior spine is that's all outpatient surgery too.
Oh, 100%. Yeah. We do it all the time.
All righty. Well, thank you both. Do y'all have any last remarks on the Spine Institute or minimally invasive procedures?
I mean, I think, being one of the top surgery centers in the country, as well as having this very comprehensive approach to spine care, I think the community is going to soon realize that this is the place to come have your back or neck pain taken care of. Because again, sometimes it's not really your neck, sometimes it's your shoulder. We can have you see our shoulder partners, or sometimes it's not really your back, it's your hip or your knee. We have a guy right next door seeing hip and knee clinic as well, and they can see you that very same day. Maybe not your neck, maybe it's your carpal tunnel. You have a bad nerve. We have hand surgeons. We have a hand institute. Maybe it's you need a hip replacement. We have a total joint institute. It's one of those things that I think adds so much value to the community, having this extra piece of the puzzle for Ortho South, to just provide the Memphis and Mid-South community with much needed support for their back problems. No pun intended.
Yeah, I think that's well said. I'll just close with that. We want to be the best based on measured by the patient experience.
That we try to make patient number one here at Ortho South, and whatever it takes for us to be able to help you shed light into your condition, to help you be better and get back functioning into the things that you like to do.
Awesome. Well, thank you both so much. And thank you everyone for taking the time to learn about minimally invasive procedures. As you see on the live stream, you can call or visit our website or just walk in. We do have walk-in clinics as well. And OrthoStat is at night at several locations. So just give us a call or visit us to set up an appointment with Dr. Weaver or Dr. Cardenas or any other of our specialists. Thank you guys so much.
Thank you guys for showing up.